PowerPoint introduction, and I apologize for the long title. That is the consequence of a long negotiation with the Lancet editors and reviewers about a paper that I will touch on. So these are my disclosures, not relevant for the talk. And I cannot give this talk without acknowledging the collaboration that I have with my Duck Hospital. And for this particular study, specifically with Dr. Vinh Dang, that you can see here. I regret it. I've not been able to visit the clinic for 2 years, but they are fantastic collaborators and have produced many of the material that I will discuss. I start with he was not a mentor of mine, Hans Evers, editor-in-chief of Human Reproduction, but he was very influential on my career when I was in the Netherlands. And he wrote a piece, Santa Claus in the Fertility Clinic, where he said that there might be an illusion, a therapeutic illusion, if we are offering many couples or maybe all couples IVF. So with that in mind, I will reflect current practice, then talk about evidence from cohort and studies and RCTs, and discuss safety and summarize in meta-analysis. So ICSI is first time mentioned in the literature, 1992, by Palermo, who applied this treatment, as I'm well informed, more or less by accident, initially in Brussels, and that led to a report on a couple of patients who were successfully treated. But then, since then, a limited number of big studies has been done, and nevertheless, there is an enormous increase in the use of ICSI. So you see some statistics here from Australia and New Zealand, where between 60 and 70% of the IVF cycles are done with ICSI. And Europe sees a similar picture here, a changing trend, where there is an increase in the number of ICSI that seems to stabilize now since 2009, 2010. These are rates from the US with a similar picture, specifically also an increase in non-male factor infertility. So is that justified? And I will first touch upon the cohort studies that are there. Cohort studies have the advantage that you can get large sample sizes. And this is a summary of the papers that have been published, the reviews published in Fertility and Sterility, where both in patients under 38 and patients over 38, there is no benefit from ICSI over IVF with relative risks of exactly 1. And here you see some characteristics of these studies. But we need RCTs because cohort studies have bias. And there are 2 large RCTs. One is published about 20 years ago, 2001, exactly 20 years ago, by Siladaticha Bhattacharya and his team in Aberdeen, who did for that time study with a very high standard, and they randomized 435 cycles in 415 couples with unexplained non-male factor infertility for IVF or ICSI. And it's important to look at the results because what they did, they put IVF, the control, on the left side and ICSI on the right side. So don't let yourself misled here, but what they find is that if you do IVF, then you have a higher clinical pregnancy rate as compared to ICSI, but it's not statistically significant. 7% difference. And if you look at implantation rate, then the difference is actually statistically significant. So there is potentially a disadvantage or harm here from ICSI. And if you look into fertilization rates per oocyte retrieved and failed fertilization, then that seems to be a little bit higher after IVF as compared to ICSI. In subgroup analysis, they could not, with unexplained infertility, their finding was the same, and it was actually a limited number of patients. So then there is a very long time, no new RCT, but in the collaboration with my colleagues in Ho Chi Minh City, my hospital, we could perform a large randomized clinical trial that has been published at ICSI last year, and it has been or presented at ICSI last year and has been published in the Lancet now 2 months ago. So this study was a multi-center, 2-center randomized clinical trial. Hospitals were My Drug Hospital and Unseen Hospital, both in Ho Chi Minh City. The study was registered and had ethical approval. And the inclusion criteria were, you see them here, women or couples who were not beyond their second IVF-ICSI attempt using an antagonist protocol, agreeing to have less than 2 embryos transferred, and they could not be treated with IVM, which is applied a lot in Ho Chi Minh City, and they could not have a poor fertilization in a previous cycle. So interventions were ICSI, the experimental intervention, and IVF applied in a standard way. And it's important to know that before the start of this study, ICSI was the standard treatment for all couples in both hospitals. The primary endpoint, live birth after the first embryo transfer, and then secondary endpoints, fertility outcomes, maternal safety, pregnancy complications, obstetric outcomes, and neonatal complications. A sample size was calculated in such a way that we aimed to demonstrate or refute a difference of 10%, and that led us from a live birth rate of 31.5% to a sample size of just over 1,000, or 532 couples per arm. And this is the randomization scheme. So there was 1-on-1 randomization was done just before the ovum pickup. So informed consent was asked earlier, but the actual randomization was on the day of ovum pickup. And then after the embryo transfer, there was a routine follow-up. So here you see the study scheme. Oh, I have to go back. We screened 6,440 couples, of which 1,000 were randomized. I only realized that when we were having a meeting halfway the study that there was such a large dropout rate, and that was because the inclusion criteria for normospermia were actually quite strict. And you see 2 groups of 532 women randomized, all were followed up, and there were relatively few deviations from the protocol. Here are the baseline characteristics, very comparable, and here are clinical characteristics of the cycles, with 40% fresh transfer and 60% frozen transfers. So the primary outcome, live birth, occurred in 34.6% in the ICSI group versus 31.2% in the IVF group. So 3% difference. That creates a relative risk of 1.11, and that is not statistically significant. So a very superficial interpretation of this study is there is no benefit from ICSI, but I'll show some more details. So the fertilization per oocyte inseminated was different, and in the benefit of ICSI, 6% different. And then total fertilization failure, not statistically significant, and and couples with without embryos, and that was statistically significant, were lower in the ICSI group as compared to the IVF group. So despite the fact that there is no benefit of ICSI on the clinical endpoint live birth, there seem to be differences in the lab. Here you see other clinical endpoints, and everywhere there is a slight benefit for ICSI over IVF. Neonatal outcomes and obstetric complications were completely comparable. So in terms of safety on the long term, there is no difference. And here you see time to ongoing pregnancy after 12 months. The little difference that occurs in the first cycles stays present later on, and it's also present after 1 year, but that is not statistically significant. So I will now share some data from the literature on safety. It's important to realize that while the RCT that I just showed is enormous informative in terms of effectiveness, these studies are actually too small to learn us something about safety. So we have to look at larger cohort studies. This is a presentation also from ESHRE last year that shows that if you compare ICSI versus natural conception, then there is a slightly increased risk of congenital malformations. But if you compare ICSI to IVF, then that difference is much smaller and not statistically significant. And this indicates one of the problems in the assessment of safety, that if you use ICSI for poor sperm, and that's usually the indication, then it's very difficult to assess what actually is the impact of ICSI and what is the impact of the underlying fertility disorder. Birth defects in children conceived by IVF versus ICSI, a large meta-analysis in fertility and sterility shows no difference. As this review, I don't know what's happening with my slides, they're going all over the place. I go back here. As in this review, where there is no difference in birth weight. And then some studies, like this one, for example, I go back again because it's an important slide. I don't know what's happening. This study, I really struggle here. This study, I'm just going to tell it, shows that there is a slightly increased risk of autism in the babies conceived after it. And now we go where my slideshow wants me to go. Apparently, that is the meta-analysis. So we're preparing a Cochrane review, and this is the material that comes from that. If you add up the studies from Bhattacharya and from Vindang, then there is, for IVF versus ICSI in normal sperm women or normal sperm couples, no significant benefit from ICSI over IVF. With the Bhattacharya study, a little bit more harm, and the Vindang study, a slight benefit. But importantly, if you split that into couples with normal morphology, defined as over 4%, or poor morphology, under 4%, then there is completely no benefit, not even a trend, in the couples with normal morphology, whereas in couples with normal sperm concentrations but poor morphology, there is a benefit that is not statistically significant. So I would say if you have completely normal sperm with normal morphology, I think ICSI is not bringing any benefit over IVF. And in couples with poor morphology, there is potentially still a benefit from ICSI. So I work in Australia, and that gives a good connection to Asia, although we currently cannot travel, but I'm very proud on this study. The protocol is published. This study is performed in a multi-center setting in China, led by Professor Ji Zhao and Professor Rong Li, who are from the Third University Hospital in Beijing. And we just yesterday had a conference call where a study with a sample size of over 2,000 is completed. And we're just doing the follow-up now. And that study is a similar comparison, ICSI versus IVF. But here we have included non-severe male infertility. So we're going to learn a lot more. And I hope, I'm not sure that we can present these results at ESHRE next year. We're going to learn a lot more about the effectiveness of ICSI versus IVF in couples with a slightly abnormal semen analysis. So I want to thank my collaborators. This was mainly work from the fantastic group in Ho Chi Minh City. Rob Norman is very supportive, and at Monash, Wang Wei, a clinical epidemiologist and gynecologist from China, is also instrumental in doing these studies. So with that, I hand back to the chair. A day without randomization is a day without progress. Thank you.
Thank you, Ben, for a very interesting presentation, but not only interesting, I think it's a very important presentation. And while listening to your lecture, most of our lab today, in most of the fertilization, the lab is done by ICSI. Why do you think it's the practice changed from conventional IVF to ICSI, that I know that some of the clinics almost do only ICSI?
Yeah, thank you for that question. I think that there are two drivers here. One is everybody is afraid to tell patients that there is a total fertilization failure. And to prevent that, people just want to play safe and do that little bit extra. So if it happens, you can always say, well, we tried everything and still it wasn't good enough. And otherwise, there might be a commercial incentive also, because ICSI brings in a little bit more money. I would point at the fact that in China, there are actually very strict legal regulations that make that clinics who do too much ICSI actually might lose their license. So one very interesting anecdote is that while we did this large study that we were just doing, that the centers were actually getting into problems because the randomization made them do too much ICSI. So if we don't regulate ourselves, I think that at some stage there might be some regulation needed, but the best thing was obviously if professionals and their professional organizations regulate themselves.
Do you have any thoughts about how can we select couples for ICSI, before doing IVF? For example, what do you think about unexplained infertility in patients who did not conceive before, and then they are coming to IVF? Should we do, half ICSI, half conventional? Should we do all ICSI, only conventional?
I would say with the data I just showed, that if you have completely normal sperm and there is normal morphology, then IVF and ICSI are not different. And I think we should always keep it as normal as possible. And ICSI is actually bypassing the whole selection process of the spermatozoa. So I would be in favor of doing IVF there. And otherwise, we're going to get some big trials, and specifically the big trial from China that I just showed is going to learn us more. I don't believe that we should put a lot of effort in all kinds of extra testing, sperm DNA, etc. For me, that has not proven any benefit.
It will be very interesting to learn how many clinics will change the practice after this presentation.
That was exactly the,
yes, and we might do a survey, after this meeting about changing concept due to presentations